All right, let's jump right in. If you're a GI trainee, or really in any specialty where you're looking at abdominal CTs, you've probably started seeing this pop up more and more, sclerosing mesenteritis. It's one of those things that can look kind of scary on a scan, but a lot of the time, it's really not. So what we're going to do here is demystify it and give you a solid, practical framework you can actually use on the wards.
So picture this. You're scrolling through a CT scan and bam, you see this. A kind of misty, hazy-looking mass in the mesenteric fat. You can see it's pushing the bowel out of the way, and if you look closer, you spot some small lymph nodes and maybe this cool-looking halo around the vessels. So what's on your differential? Right? Is it lymphoma? Could it be carcinomatosis? Or is it this thing we're talking about, sclerosing mesenteritis?
So here's our game plan. We're going to tackle this like a real diagnostic detective story. First up, we'll figure out what this whole misty mesentery thing is all about. Then, we'll get into the nitty-gritty of how you actually diagnose it. After that, we hit the big one, the cancer connection. Then, we'll talk patient management. And finally, we'll wrap it all up with the key takeaways you need to know.
Okay, section 1. Let's start with our very first clue in this case, that classic misty mesentery. This is the finding that gets the ball rolling.
So what in the world is it? Well, sclerosing mesenteritis, or SM for short, is basically an idiopathic inflammatory problem. We don't really know what causes it. It all happens in the fat tissue of the mesentery, that membrane that kind of holds all your intestines together. The key concept here is that it's a spectrum, a whole continuum of chronic inflammation, fat breaking down, and then scarring or fibrosis. Now, if you dig into some of the older papers, you're going to see a ton of different names for this thing. It's been called mesenteric paniculitis, retractile mesenteritis. The list goes on. It was super confusing. But now we understand these were all probably just describing different stages of the same disease. So to make everyone's life easier, the field has settled on one unifying term, sclerosing mesenteritis. Let's stick with that.
And here's a really important clinical point. A huge chunk of these cases, we're talking about 60%, are found completely by accident. The patient's in for a scan for kidney stones or something totally unrelated, and this just pops up. They feel totally fine. Now, for the other 40% who do have symptoms, it's usually things like abdominal pain, bloating, maybe some changes in their bowel habits.
So, let's move on. We've got our first clue. Now, how do we follow the evidence and lock in a diagnosis?
Luckily for us, we've got a great diagnostic checklist called Coolier's CT criteria. Just think of these as the 5 classic signs. It starts with that hazy mass we saw, and on the scan, that area is going to look a bit denser or brighter than the normal fat right next to it. Next, you look for lymph nodes, and the key here is that they're typically small, less than a centimeter. Then there's the classic halo sign around the blood vessels. And finally, the whole thing might be nicely wrapped in a thin fibrous shell, a pseudocapsule.
And here's the practical rule you can use. You don't actually need to find all 5 of those features. The clinical rule of thumb is pretty simple. If you see 3 or more of these criteria on a CT scan, you can be pretty darn sure you're looking at sclerosing mesenteritis. Which, of course, leads us to the million-dollar question for any clinician, right? Do I need to stick a needle in this thing? When is it safe to say, you know what, we don't need a biopsy?
Well, you can absolutely make a presumptive diagnosis, no tissue needed, in the right setting. It's a 2-part test. First, the imaging has to be classic. It's got to hit at least 3 of those Coolier's criteria we just talked about. Second, and this is just as crucial, the patient cannot have any alarm features. We're talking about those B symptoms like fevers, drenching night sweats, or losing weight without trying. If both of those conditions are met, you can be very confident you're not missing a malignancy.
And that's the perfect segue into the most critical part of our whole investigation, the cancer connection. We have to be absolutely sure we're not dealing with a dangerous imposter here.
Think of this as your cheat sheet for telling SM apart from its most common mimic, which is usually lymphoma. On the left, you see the good signs, the features of SM. Small nodes, less than a centimeter. On the right, those are your red flags for malignancy, nodes bigger than 1 centimeter. The halo sign, that's a friendly finding. If it's absent, that's more suspicious. SM is usually contained, while cancer can cause big lymph nodes elsewhere. And finally, SM tends to have a smooth border, whereas cancer can look spiky and invasive.
So what's the actual risk here? Well, for patients who have those classic SM features and none of the red flags at diagnosis, the chance of them later developing a cancer, and it's almost always a B-cell lymphoma, is only about 1%. That's a pretty reassuring number, right?
but it does tell us we need to keep an eye on things, at least for a little while.
So here's the bottom line, the crucial takeaway. Despite that small association, the current evidence does not support the old idea that SM is a paraneoplastic syndrome. In other words, it's not a sign that your body is reacting to some hidden cancer. It's its own separate inflammatory condition that very rarely can be seen alongside lymphoma.
Okay, we've made our diagnosis, we've thought about the risks, now let's build our action plan. How do we actually manage these patients?
If you remember just one single thing about managing sclerosing mesenteritis, let it be this mantra. Treat the patient, not the scan. I mean it. Just seeing it on the CT report is not a reason to start treatment. It all comes down to symptoms.
So what does that look like in practice? Well, our management plan splits into two paths. For that big group of patients, the asymptomatic ones, we just watch and wait. The recommendation right now is to get a follow-up CT scan once a year for 2 years, just to make sure everything is stable. If it is, you're done. No more routine scans unless they develop symptoms. Treatment is only for the patients who are actually feeling sick from their SAM.
So what do we use for those symptomatic folks? The two most common first-line drugs are prednisone and tamoxifen. Prednisone works great to put out the fire quickly and help with symptoms, but that benefit often disappears once you taper the dose. Tamoxifen is really the long-term workhorse here. We think it has antifibrotic effects, and it works in about 50 to 60% of patients. Often, you'll start both together, taper the prednisone, and then continue the tamoxifen as a maintenance therapy.
And that brings us to the end of our case file. This is the final report, the high-yield stuff you need to remember for your next shift. Let's nail this down. Number 1, SIM is its own inflammatory thing. It's not a sign of hidden cancer. 2, you can confidently diagnose it with 3 or more of Colliar's CT criteria. 3, most patients have no symptoms, so remember, treat the patient, not the scan. 4, you only need a biopsy if you see red flags, especially lymph nodes bigger than a centimeter. And 5, when you do need to treat, tamoxifen, with or without a prednisone taper, is your first move.
And I'll leave you with this final thought. We know this is an immune-driven disease, yet our treatments are still pretty broad. As our understanding of immunology gets deeper and more precise, what's next? Will we start using highly targeted biologic therapies? Could the future of managing SM look completely different? It's a really interesting question to think about.